in the rehabilitation team could not be overemphasized, in the sense that the nurses spend more time with patients when they are in admission, when they are on hospital admission, please. And because they spend more time with the patients when they are on a hospital admission, the nurses tend to bond better with the patients than any other professional. In short, before you know it, the patients we confide more in the nurses than any other member involved in the rehabilitation team, because these people spend more time with them and also assist them with some of the services their family members should do for them. I remember in the hospital a patient who was booked for amputation. The patient stayed in the ward for 2 days. After much, he said, no, that is not going in for the surgery again. So after investigation, it was found out that it was the nurses and the ward maid in the hospital that have poisoned the mind of the patient not to go again for that surgery. You see that these people, they play a very important role, because even when you are giving your prescriptions to the patients, by the time they retire to the ward or being admitted to the ward, they interact with the nurses, even the ward maid. They are another important group of persons, but I will come to that. So because these people spend more time with them, unlike the physiotherapist from the clinic you go, the prosthesis from the clinic you go, even the doctor from the clinic you go. But these people stay with the patients in the ward. Even at times you see some patients who don't have a relative staying with them. The nurses will be playing the role of the nurses and that of the relative to them. I've seen cases that you see patients, there are people, friends and well-wishers, sending money to them through the account of nurses or ward mates. You see, because they spend more time with these people, they bond better with them, and they have a lot of decisive influence over the patient. At times, you might advise a patient on a treatment plan. The patient will agree. After a day or two, or even after some hours, they will come back and say no, that they won't oblige to that treatment. You know that such influence is coming from the people around them. And prominent among these people is the nurses. So the nurses play a very big role in the rehabilitation of the patients. They influence their decisions a lot because of the more time they spend with them. So a rehabilitation nurse plays a role to help patients regain their independence, regain their health, well-being after an illness, injury, or surgery. Like patients that have open wound, the nurses will dress the wound. Even at times, patients that might need to go from one unit to another, while the ward med wheels them to that place, you see the nurses carrying their folders. So the nurses are deeply involved in the rehabilitation of patients. They are a very important member of the rehabilitation team whose role cannot be overemphasized. Then another member of the team is the occupational therapist. They play a key role in rehabilitation team by helping people regain and maintain their ability to perform daily activities or occupations. OTs work with patients to identify their goals and create tailored interventions to help them overcome their challenges. The occupational therapists help patients to adapt to their daily activities and occupations. Somebody might have injury, illness, or sickness that might have affected their functions, that there are things they do before which they might not do or do it perfectly again. The OTs will come to help such individuals to, despite their limitations, despite their disabilities, to still cope with their daily activities and occupations, so that their deformities, their challenges, physical challenges or mobility challenges will not throw them out of their work. but to encourage them, to train them, to teach them, to assist them how to live with their challenges and still go on with their daily activities and occupations. So here are some of the ways the OTs could help people or patients undergoing rehabilitation. One is to identify their needs. The occupational therapist will assess each patient's uniqueness or unique needs and limitations. The OTs will come in to know what are the unique needs of these patients. Then what are the things limiting these patients? If the need of this patient is maybe the work the patient is doing requires the person to stand like 4 hours a day or requires the person to sit 3 hours a day, what are the limitations this individual is having now that might not permit him to start for 4 hours a day or to sit for 3 hours a day? When such needs and limitations have been identified, then they will go ahead to set a goal. What are the treatment goals? So the OTs work with patients and their families to identify goals that are important to them. When these needs and limitations have been identified, the OTs now will set the goals, what they want the patient to achieve at the end of the rehabilitation plan or exercise. Working together with their family members, they will set a goal. They will set goals, the treatment goals they want for that patient. Then another role the OTs could play in the rehabilitation plan of a patient could be to help the patient improve their skills and provide suggestions for overcoming challenges. For example, they may break down a task into steps to make it easy to perform. So the OTs will help the patients to improve on their skills. Take, for example, if the patient now has a challenge to sit down or have a challenge when trying to sit down, the OTs might break the process of sitting down or bending down for the patient to say, instead of sitting down at a stretch, you first do this. By the time you hold this, you do this, and you see that that task now will be easy for the patient to perform because the patient has learned additional skill of how to do that thing. Something a patient has been doing all this while, but because of such challenges or deformities or injury, the person cannot do it efficiently the way the individual used to do it before now. The OTs will come and teach the patient other ways of doing that particular task, which will appear easier for the patient. The OTs will also help to teach the person self-management. The occupational therapists teach patients self-management, compensatory and adaptive skills. There are some skills the person need to acquire or how to manage oneself. That's what we call compensatory skills. You can use one skill or technique to compensate for the one you don't have. Take, for example, the person might have lost 3 fingers, that only 2 fingers are now left. The person could be taught how the 2 fingers can compensate for the functions of the 3 fingers that have been lost there already. They also help to foster independence instead of living a sedentary lifestyle or depending on people to live your daily normal activities. The OTs will help such individuals not to be dependent so that they can be independent. They don't need people or they don't need to depend on people before they can go on with their daily normal activities. Then another group of people or professionals very important in the rehabilitation team is the speech/language pathologist. Some people call them speech therapists. Some people call them speech/language pathologists. They are also known as speech therapists who play a key role in rehabilitation teams by helping patients improve their communication and swallowing abilities. So people who have communication or swallowing inabilities will see the speech to language therapist who will help them to improve on their communication with people and ability to swallow. The roles of the speech and language therapist are not limited to one, diagnosis and treatment. As I said earlier, that any problem you don't understand, you cannot solve. So part of the things they do is to do a thorough diagnosis of what the situation is. Speech/language pathologists assess and they treat a variety of communication and swallowing disorders in people of all ages. They create customized treatment plan to meet each patient's need, telling on that each patient has his or her own peculiarities. So they will diagnose and then fashion out a customized treatment plan that will be peculiar to that patient's need. Another role they play is education and training. They will educate the patients and their family members on how to comply with the treatment plan, because some of the things they might tell the patient to do might be things the patient will do at home. Is not all the treatments are being rendered in the hospital or clinical setting, that at times the patient might need to continue their management from their homes. So the speech or language pathologists will train and educate both the patient and their family members on how to continue their rehabilitation exercise or plan at home. So the ones they need to do at home, they will do, while the ones they will need to do in the hospital or clinic, they will visit the hospital for those ones. Another role the speech/language pathologist might play is collaboration. The speech/language pathologist work with other professionals in the rehabilitation team to deliver services. Of course, they will collaborate with other team members. Research works and even evidence have shown that. Okay, somebody is raising up his hand. San Najib. If you have a question, you might need to wait when we finish to ask your questions. But I think you people can hear me. Hello?
Sorry for that.
Yes,
We can hear
can
you,
hear
sir.
you.
We can hear you, sir.
Okay, so sorry, the person raising up his hand, if you have a question, you might need to hold it so that at the end of the section, we might take questions and contributions or comments. So one of the roles a speech/language pathologist may play is collaboration. I said that even evidence have shown that when patients, when we use a multidisciplinary approach in rendering treatment and services to patients, the outcome is always better. So there is this need to collaborate with other professionals in the rehabilitation team so as to get a better treatment outcome for the patient. We also have another role as group therapy. The speech/language pathologist might provide therapy services in group settings. They might group those individuals they are treating, link them up to different groups, so that when you have people that have the same challenge with you, by the time you interact with them, take for example, if you have different persons in a group who share the same problem or challenges, if your own rehabilitation state is at maybe 20%, people who have gotten up to 50% can now encourage you and even tell you their own experience to say when my own was at this your stage, look at some of the strategies I adapted that helped me to cope. You see that when you link them up in such group, they communicate, they share their adaptation strategies, which could be beneficial to one another. So they also help to have to rehabilitate them in groups, maybe linking them up into different groups where they can share their experiences so other people who are passing through the same condition could learn and also adapt such coping strategies which other members of the team adopted during their own time. Another role the speech/language pathologists could play is swallowing observation. They may need to observe the patient eating to identify if there is any swallowing difficulty. That will help them to appreciate the problem better. They also could give home-based therapies. They might lay the groundwork for self-treatment and home-based therapies. They visit them at homes and continue there. Then another important member of the rehabilitation team is the social workers. Social workers play a vital role in rehabilitation team by one, providing emotional support. We know that these people who are challenged physically go a lot of emotional trauma and discomfort, in the sense that some of them were not born with some of these challenges, that some of the challenges are acquired. So imagine somebody who could stand up, run, do every other thing. All of a sudden, the person could not do such thing again. You see that emotionally the person will be down, emotionally the person will be traumatized, seeing yourself looking different from others, seeing yourself all of a sudden things you could do before now, you cannot do it again. So the social workers help to provide emotional support. They help patients cope with the emotional impact of disability and help them to build resilience. This is very, very important. You might even see some patients when they come to hospital. Let me use amputees for example. Even when you have finished fabricating a very befitting prosthetic device for the patient might say they don't want to use it because they are still emotionally down. They have not summoned the courage to say life, all hope is not lost. There is still life after amputation or deformity. So you see some of them that no matter how good the treatment plan might be, no matter how we have fashioned it, they might not even be compliant. They might say no, they don't even want. You see that such thing now is coming from emotional trauma, that they need somebody to work on their emotions before they will even oblige to the treatment plan you have for them. Then another role of the social worker is helping families. Social workers help families deal with social, financial, and emotional impact of an illness. We know that quality medical treatment or services are expensive everywhere. And the worst in our own climb here is that there are no social insurance or securities that help people to cope with the financial burden of their rehabilitation treatment. In short, in the NHIS we even have, most of the rehabilitation services are not captured in the NHIS. I know that the acquisition of artificial limbs are not captured in the NHIS. You see that it becomes a very big problem that most of the services we render as rehabilitation professionals are not captured, even to acquire assistive devices. You see that even the NHIS that is available is not captured in the NHIS. You see that people undergoing rehabilitation treatment spend a lot because most rehabilitation treatments last long. Some of them might take years. Some of them might even be a lifetime rehabilitation treatment that the patient might need to undergo. You see that it involves a lot of money. So these social workers could help the patients to cope with these financial needs. At times, you might see some patients in the hospital they have been treated and discharged, but they can't go home because they have not paid their bills. The social workers might go out to philanthropist organizations, get people who will come to help those people to defray their bills so that they could go home. So it's part of the work of the social workers helping the families with the social aspect, financial aspect, and the emotional aspects of the illness or sicknesses they have. Then also the social worker can play the role of coordinating care. Social workers coordinate patient care during hospitalization after treatment. They coordinate in the sense that they visit the patient to know their social needs and how they are doing. They might visit the patient will say, this doctor is supposed to come and see me. This professional is supposed to come and see me, but I have not come. They will take it up to that unit. In short, before we had Savicom in different hospitals. It's the social workers that we are doing that work of Savicom, which I don't know in some hospitals that are even incorporated into the services of the Savicom. They visit the patients to know how far their treatment is going. Where the patients tender some complaints, they might take it up to say, this nurse is supposed to come and take me for to X-ray unit. They have not come. This person is supposed to see me. So you see them trying to coordinate, linking the patients up to different professionals or units that they might go and benefit useful treatments for them. Then also coordinating psychosocial assessments. Social workers conduct psychosocial assessments like knowing how the psychology and the social well-being of the individual is. They also do advocacy. It's part of the work of the social workers. They also connect patients to resources. Social workers help connect patients to community resources to support rehabilitation and independent living. They also help in planning training programs. Social workers participate in planning and organizing training programs for people living with disability. At times, people living with disability, you see some of them because of their challenge, they didn't go to school to a certain level. Some of them don't have any handwork, they don't have a trade. You see that the social workers, when they gather these people and get their contact from the hospitals, they can go as far as getting people who could come do a form of training for these people, the vocational training, so that they will have skills. Because in our own country here, you see that the disability is like a certificate for people to beg for arms. I remember one amputee, we helped to get an NGO to donate a prosthetic limb to the amputee. The amputee refused and said, no, we should better give him the money. But the NGO said, no, they don't give money, they only give limbs. You know why the amputee refused the donation of the prosthetic limb? Because he feels the limb will take him out of the street so that he won't beg again. The disability, the amputation he had, has given him occupation, and the occupation is to beg for alms. So when we got the NGO to donate limbs to the man refused because to him, he thought I want to take away his means of livelihood, which is begging for alms. So you see that at times, most of them are misinformed, that they need a form of training or education to tell them that this disability is not the end of their life, that despite this disability, they can still be useful economically, socially, and otherwise. So when you organize such trainings and even bring people who can train them on vocational skills, you see that they are reintegrated better and become very independent, both economically functionally and otherwise. Also, part of the work of the social worker is creating public awareness. Social workers organize public enlightenment programs to help create societal acceptance for people living with disabilities. They are like advocates of the people living with disabilities. They go to hospitals. This hospital does it have a ramp that will permit people with wheelchair to access the building? You see, even in some hospital settings, you might see buildings where patients should access treatment. It will only have a staircase without a ramp so that people with wheelchair and trolley can access the building. So it's part of the work of the social workers to create such public enlightenment to remove that segregation towards people living with disabilities. They also work with family members and the patients to fashion out better ways to help such individuals with such disabilities or illnesses. Then another member of the rehabilitation team is the prosthetics and orthotists. Really, the prosthetics and orthotics is like a combination of two closely related professions. The prosthetics makes the artificial body parts, while the orthotics makes appliances that supports a weak, a diseased or deformed body part so that it could perform its functions. So prosthetics and orthotics are members of a rehabilitation team who assess, design, fit devices to help patients with limited mobility. So people who have mobility challenges that will require devices, the prosthetics and orthotics make such devices. Prosthesis creates artificial limbs for people who have missing limbs or have a limb that is no longer functional. They work with patients to design prostheses that meet their functional and cosmetic needs. Prostheses also teach patients how to care for their prostheses. Then orthotics deals with the design or fabrication of devices that will support, but not to take over the function, unlike in prosthesis. A prosthesis takes over completely the function of a missing body part. But orthosis, the body part is still there, but is limited in performing its intended functions. Now you get a device that could be attached or fitted on that body part to help it to perform its functions. So the processes also work with the patients, with their family members to make sure that their rehabilitation exercise as targeted against the right attention as targeted or outlined in the treatment plan or goals. So they try to design, fit, maintain those devices that will help people with mobility challenges cope with such challenges and reintegrate them back to the society. Then we have the audiologists who are experts in rehabilitation of hearing and balance issues and play a central role in rehabilitation teams by one, assessing and diagnosing patients. They will assess, they will diagnose, know what the problem is. Audiologists identify, they test, they diagnose hearing, balance, tinnitus disorders. They also interpret test results. So all this goes to tell you that they will assess and diagnose. Then the next role they play is counseling. Audiologists counsel patients about hearing health and the need for treatment. Some people might even have the need to see an audiologist, but they will say, let me continue the way I am. So there is need to counsel them to tell them the need, and also there is a solution to their problem. Then the audiologists also fit hearing aids. When the hearing aids like cochlear implants are produced by the biomedical engineers, is the audiologist that will fit and train the patient on how to fit and remove these hearing aids, because some of them are not fitted permanently. There might be when the patient wants to use it is in place, when the patient is sleeping or not using it is removed. So they will fit these hearing aids on the patients and also educate them how to fit or remove it if it's the ones that are removable, for the ones that are not implanted permanently on the patient. Then they also provide the rehabilitation, they provide training and treatment to improve hearing and balance and maximize a patient's quality of life. We know that when an individual has a hearing problem, the individual's quality of life is reduced. But when such individual is rehabilitated by an audiologist, you see that the quality of life is enhanced. Screening, which also goes with assessment. Then evaluating communication, they help to evaluate the the audiology screens speech language, sign language, and other factors that affect communication, which also goes with assessment and diagnosis. Then another important member of the rehabilitation team is the psychologist. A rehabilitation psychologist plays a key role in helping people with disabilities and chronic health conditions improve their quality of life. Their responsibilities are not limited to one, assessing and treating or treatment. Rehabilitation psychologists assess and treat a range of difficulties, including emotional, cognitive, and functional challenges. They also help people overcome barriers to participating in life activities. Take, for example, people who are to go for amputation. Most times in ideal situation, not most times, in ideal situation, such person should go for thorough counseling by a psychologist, because we had stories of people going for amputation. By the time they woke up from the anesthesia, they see that their limbs are not there. Some might even want to commit suicide because their mindset was not prepared before that amputation. So the psychologists play a very important role in pre and post amputation counseling. Even people who have other deformities, take for example somebody who fell down from a height and had problems with the spine, that the individual cannot walk again, that the individual now is restricted to be on a wheelchair. You see that if that person is not well counseled, the person might want to kill his or herself one day out of frustration and emotional trauma. So the psychologist will help to counsel such people, tell them that there is life after such deformities or challenges, prepare their mindset. Even some amputees, before their amputation, don't even know there is something like prosthetic restoration and rehabilitation, because nobody told them about it. But if there had been a psychologist who will counsel them, tell them that even after you benefit from the amputation surgery, there is what we call prosthetic restoration and rehabilitation, where you will get back your limb, that nothing is lost. You see that that patient will feel reassured. You see that that patient will feel that yes, there is still a life after amputation or such deformity or mobility challenge. But at times you see that patients don't even have the right information. Some of them don't even know that there is a way out of their situation. They don't know that their challenge could even be made better or improved on. So there is need to talk to these people by psychologists, either pre or post amputation or deformity, so that they will know that there are a lot of devices, there are a lot of gadgets, there are a lot of technologies that could be used to improve their situations, and they will bounce back, if not completely to their normal lifestyle, but very near or close to their normal lifestyle. Also, another role of psychologists is providing education and advocacy. Rehabilitation psychologists can help clients set goals, tailored treatment, and advocate for themselves to access resources and specialized equipment. They will help to educate them. As I said earlier, some of them don't even know that there are devices they need to benefit from. Some of them don't even know that such treatments exist which they can benefit from. So by the time they are given this information, they are better equipped, they are better disposed to cope with such challenges they are facing. Then, another role of the psychologist could be teaching adaptation. They teach patients how to adapt and make lifestyle choices that promote good health. Considering all factors, rehabilitation psychologists consider all factors that contribute to well-being and recovery. So they look at the patient holistically. This one, have you benefited from this one? Have you seen a prosthetist? Have you seen a physiotherapist? Have you seen an occupational therapist? Have you seen this person? So they look at the patient holistically, looking at all professionals or technologies or available options that are there for the patients to ensure that they have really benefited from all available options that will help them to cope with their mobility challenges. Then another important member of the rehabilitation team are the family members and friends. Family and friends play a vital role in the rehabilitation process by providing emotional and physical support, and also helping patients recover from disability or life-threatening diseases. One, let's look at emotional support. Friends and families can listen and reassure patients, helping them avoid anxiety and self-doubt. In short, the family members play a very important and crucial role in rehabilitation team. One, there are at times you might be explaining a particular treatment plan to a patient. The patient who is already traumatized emotionally and otherwise might not even be giving you a listening ear. But by the time you talk to a family member, the family member will understand you better and go to convince the patient to say, yes, I have spoken with the professional, I have spoken with the physiotherapist, I have spoken with the audiologist that this treatment is the best for you. And you see them oblige because their family member has spoken to them. Why this is what you as a professional have spent your whole time, your whole day talking to the patient, and they don't want to oblige to that. Also, when the patient see their family members by their side, providing their financial need and physical needs, they feel better. That anxiety and self-doubt is eliminated, that really they have people who are giving them support. Unlike you tell a patient, this is what you need, nobody to provide it. This is what you need, nobody to provide it. You say that the person will even be weighed down the more. Even you as a person will even be discouraged in prescribing further treatment plans or rehabilitation plans for the patient, because the first one you prescribed, the patient have not done it. Your physiotherapist might say you need 2 sections a day. The patient has not even paid for 1 section. So you say that you will be tired, you will be discouraged to make further prescriptions that the patient will benefit from, because the one you have prescribed already, the patient and relative have not obliged, because the relatives or family members are not giving that financial support. So the family members play a very big role in the rehabilitation team. In short, most of the things we do depends on the family members. Because when you say the patient needs this, it's them that will foot the bill. They will need this, it's them, and also need to give that emotional, physical, financial support so that the patient will be reassured that, yes, I have people beside me. Another one is accountability. They can remind patients of their goals and celebrate their achievements. When you integrate the family members into the rehabilitation team, they can help you to monitor the patient's compliance. Take, for example, you have designed a spinal brace for a patient, and the patient is to wear it 23 hours a day. You don't live with the patient at home. But if you integrate the family members and tell them, see, this is how it should be, they will help you to monitor the patient so that the patient could comply. Even when the patient forgets, they will remind the patient, you have not done this. So the physiotherapist said you should ride your bicycle 3 times a day. You have only gone for one section. You have not, two is left. Even they might even help when the man is or woman is doing those tasks. They might help to be celebrating the person. Ah, you have completed the first section. They clap, they make it funny for the patient, and you see the patient adapting and coping easily because the family members are there to cheer him or her up, because the family members are involved in the rehabilitation and treatment plan of the patient. So the family members and friends are very important members that should be included in the rehabilitation team. Another role the family and friends could play is practical help. They can help with tasks like cleaning, taking patients to therapy. At times, we work in different hospitals. That at times you see that some hospitals are seriously short-staffed. You might be waiting for when a ward maid will come and wheel patient to physiotherapy clinic for a section. Time will be going because that ward maid might have taken one patient to the other place that you are waiting for him or her to return. But when the family members are part of it, you can even see family members, they will volunteer. At times, I have seen family members in hospitals that are the ones moving their family members on a wheelchair to a particular unit or clinic where they need the specialized treatment. So they play a very important role. As I said, you might go to some hospitals, you see that they are seriously short-staffed. You might see a whole ward, a ward of maybe 20 or 30 patients. You see only one or two ward mates that they can't do that work efficiently. But the family members could be incorporated to do a practical help. Instead of to continue waiting for the ward mate to come, they will be the one to take their relative to a particular clinic or unit where they will benefit from a treatment. Another role of the family member is encouragement. They can motivate patients to participate in therapy and other activities. If it's to be a pediatric patient, the parents might even decide to buy him or her a gift. If you do this one, I will give you this. They try to entice the patient up, and you see the patient, they will be encouraged, they will do better, and you see the rehabilitation outcome will be better because the family members are integrated. Another one is education. They can learn about the rehabilitation process, including the nature of injury, treatment option, and expected outcome. They will even help you to monitor your outcome. You tell them that this your brother is using crutches. Is expected that after 2 weeks, they will drop crutches and use walking stick. They will be the one monitoring itself to tell you, doctor, this, that, 2 weeks has come and gone. No, he's still using the crutches. So because they know what the expected outcomes are, they will help you to even monitor it to say, yes, now he's doing better. Now he could do this by himself. Now he could do that by herself. So they even help you to monitor outcome to tell you, yes, there are recorded successes or not. Also, when they you educate them on the do's and don'ts, they will even help you. Take, for example, a patient had a fracture that you don't want the patient to bend or make any movement. When the patient unconsciously makes such movement, they might remind the patient, you didn't hear what doctor told you. You didn't hear what physiotherapist told you. They said you shouldn't do this and you are doing it. You see now they're helping you to monitor compliance because you have educated them properly on what the patient should do and what the patient should not do. Another role of the family and friends is advocacy. They can advocate for patients because they know them best. These people know the patients the best because they are family members, they are friends, they have lived with them over a lifetime. So they know better what they want, they can advocate for them. Also, transition, they can help patients ease back to their home environment, especially if they also serve as caregivers. They can help them. Take, for example, because they have been involved in the treatment, you tell them that this patient is not supposed to be climbing stairs. By the time they go home, they might make an arrangement to say, no, doctor said that he shouldn't climb stairs again. He will be living on the ground floor. They make arrangements at their home environment that suits the rehabilitation plan because you carry them along. They know the do's and the don'ts of the treatment plan their person is undergoing. So the family and friends, they play a very, very important role in rehabilitation team, and that's why they should be involved in such rehabilitation team so that they understand the treatment better. They will help you to monitor the progress. They will even help you to ensure compliance when they are person, because some patients might be so stubborn that you tell them to do this, they won't do. But even when you come, the person might be lying to you to say, yes, they have been doing it. But their family members might be the ones to tell you the truth. Say, no, don't mind him. Oh, he has not been doing this, has not been doing that. So they play a very big role in rehabilitation team. Then another people in the rehabilitation team are the community health workers. Community health workers play a vital role in rehabilitation of persons with disabilities by improving their quality of life and building community capacity. In short, these people, the community workers, they are majorly at the primary health centers. And part of their role is to facilitate access to services. Some people who visit the primary health care centers don't even know that there is a profession called occupational therapy. People in the local setting might not have heard of something like praise and orthotics since their life. In short, some of them who have benefited from amputation thought that the only thing they could use is crutches. Apart from crutches, they don't know of any other device that could help them. So these people who are the community health workers are the ones most times who will link these people up to the tertiary health institution or professional where they will get these professional rehabilitation services. Because people in the local setting, some of them, if you tell somebody who is having a speech problem in the local setting, there is a profession called speech stroke language therapist. They will say, this one doesn't exist. Oh. So these people who are the community health workers, they serve like a link who will facilitate access to services. In short, I had a friend who worked as a priest and orthotics in one of the neighboring African countries. So there, the priest and orthotics professionals are very scarce. What they do with these community health workers is that the community health workers will gather the amputees in the local setting. The day they go, they call it mobile P&O clinic. They will go that day, take measurements, and go back to the city. The next day, and fabricate those devices. The next day they will go is for fitting of the devices, and the physiotherapists will follow up and do the gait training in a day or two for them, and they go back to the city. You see now the community health workers now are like bridge. They are bridging that gap. They are the ones who will gather these people in the local city that cannot come to the town because they don't have access. So they use their mobile P&O clinic, go to the village setting. In a day, they will take measurements go back to their base in the tertiary health institution, do the modification, fabricate the devices. The next day, they are going with the physiotherapist. By the time they are fitting, the physiotherapist is doing the gate training. You see now that the community health workers now are serving like a bridge, linking the people in the locality to the who can't come and access services in the tertiary health institution. They now serve as a link, helping them to have that access. And I think that is what WHO Rehabilitation 2030 agenda is working towards, to have rehabilitation services at the primary health center, so that the primary health centers, even if it means counseling, even if it means advising, so that those people who come to the primary health center that cannot access the primary health center, the tertiary health institutions, could now have a link. So that's part of the focus of the WHO Rehabilitation Agenda 2030, to make sure that we have rehabilitation services at the primary healthcare level, which is the basic level of health treatment, of healthcare, please. So another role they could play is improve quality of care. The community health workers, close understanding of the community, they serve helps. Sorry, they help. Sorry, the community health workers, because of their close understanding of the community, that helps them to improve the cultural competence of service delivery. So, because these people are that primary level, most of them are from that locality, they understand the culture of those people better. They will help you that while you are rendering services to them, you also observe their culture. I remember one man we made a prosthetic limb for with the prosthetic limb was black. The man rejected it. A story my friend told in his clinic, that he made a limb for an amputee, and after fabricating, the socket was black in color. The man rejected it, that black connotes evil, that according to their culture, you don't put anything black on the body. So had it been that it's somebody from that setting was involved, the person will advise better to say, no, our people here, they don't take anything black. So use any coloration to tamper the color so that it won't be black. So these people, because they are, most of them operate in that cultural setting or locality, they understand the culture better, because most times when you are treating people, you also need to observe their culture, because there are a lot of cultural differences. So there are things you might do, they say you are going against their culture, this, that. So they help you to blend culture and maybe people's tradition, or respect people's tradition and culture as you render rehabilitation services to them. Also, they build community capacity. Community health workers increase health knowledge and self-sufficiency through activities like outreach, education, counseling, social support, and advocacy. So I mentioned it earlier that they do a lot of outreach. They can gather these people, tell them, see, there are professionals that could help you with your deformities, even social support, advocacy. So these community health workers play a very important role as a member of rehabilitation team. They also promote rehabilitation activities. Community health workers can support and implement rehabilitation activities at the community level. They are the people who have there. Even if the person might not be a physiotherapist, an occupational therapist, but when they have a little idea that there is this profession, this is what they do, they can help to promote rehabilitation activities, because they'll be able to communicate to the patients. See, there is this professional, this is what they do for you, this is what they should do for you. And you see that at the end, they help to promote rehabilitation activities. Then another member, though I didn't capture here, is the ward mates, which I mentioned earlier. They are very, very important. They are the ones that move the patients around from physiotherapy units. They go to OT. From OT, they go to P&O. So they play that good role of assisting in patients' rehabilitation. They move the patients around. Patients will come. The patients that are on wheelchair, they will be the ones to wheel them in. And I told you earlier that they blend very, very well with the patients. That most times you see the word made. They are the ones influencing the decisions of patients. At times you might see a patient book for surgery or maybe schedule that this rehabilitation expert will attend to them. They will come and tell you, no, we don't want this man. They will even tell you that it's somebody they have not met before that will attend to them. You'll be wondering, now who told them about this doctor? Who told them about this physiotherapist? And you have to respect patients' will. You don't know that is this what makes them have told them, this person is not competent to wait for this person. This person, when he conducts surgery in the theater, patients do die very, very well. Oh. You see the patient, they will say no, they won't want this man to or woman to operate on them. They need so doctor. So you see that is these ward mates who spend more time with them and also plus their level in the society. They are very, very good at gossip. Sorry for using that word, but they blend better. You see that this word made, they influence the decisions of the patients most. So they also play a role in a medical rehabilitation team. Then another thing we might look at here is the appropriate etiquette for meetings and conferences. While we are in a rehabilitation team, there are some professional from professional or social attributes we should possess in order to be effective and also be responsible and responsive in such rehabilitation team forums. And part of this etiquette is one, you have to be on time. You don't schedule a meeting for 9. And funny enough, you might have your seniors, your senior colleagues who are attending the same meeting. You see them on time waiting for you. So we should try to be on time. When you are on time, it makes you look responsible. And also when you schedule meetings, because people know that you respect time, that you are time conscious, they will always be there because they know that you don't come late. So being punctual shows respect for others' time and is a sign of professionalism. A meeting could be scheduled by 10. You know that in hospital setting, people have a lot of schedules. The person might have a section of procedure he wants to administer to a patient by 11, and he has programmed that meeting to last from 10 to 10:30. Then you are coming by 10:30. That meeting must have dismissed, and they will begin to see you as not being responsible, and there could not be any cogent reason why you are joining the meeting late. So always try to be on time. It will accord you respect as it shows respect and professionalism to others. Another etiquette we need to do is to dress appropriately. Appropriately in the sense that every setting has its own mode of dressing. Take, for example, you are going into the theater, you should wear your robe, sorry, your scrub. You are going for professional meetings, you don't dress casual. Every meeting or environment or setting has the appropriate dress you should put on. So make sure you dress appropriately. Even when seeing patients, as I tell people, that patient will first build confidence in you before they can accept you to treat them. There is a way you will appear before a patient. Even that confidence, that trust, the patient will not repose it on you. Because looking at it, for example, you appearing to a patient, you have your hair, the dreadlock, you are wearing jeans that is torn all over. The patient will not see you as a serious-minded professional. So if the same applies for meetings, when you are going for meetings, it could be the first time you are meeting people whom you have not met before. Your appearance will make an impression of you. So you make sure you dress appropriately. There is a saying that people are addressed the way they are dressed. So by the time you dress responsibly, people will address you responsibly and take you seriously. But when the reverse is the case, we know what it means. Also, in such meetings, you should mute yourself. In video conferences, mute yourself when you are not speaking to avoid background noise and self-bandwidth. So if it's to be virtual meetings, when you are not the one presenting, mute yourself so that you don't constitute nuisance to that meeting. Also, if it's to be a physical meeting, when you go in, put your phone on vibration so that you don't distract or interrupt people with your phone when it rings. Because by the time your phone rings, you interrupt the person who is presenting. And by the time that is over, the person might forget what he or she was talking about. Because you might distract people. After distracting the person might forget the point the person was trying to make before your distraction came in. So learn to mute yourself. If it's a physical meeting, learn to put your phone on silence or vibration mode. If it's to be a virtual meeting, mute yourself when you join. Only when you are given the forum to speak, you can now unmute and speak. Another etiquette you should go for is ask for the agenda of the meeting. When you know the agenda, you follow it as it has been presented. If it's to be a presentation you are making, go ask for the course content or course outline so that you follow it the way it has been given to you, so that people won't see you as talking off point. Because no matter how brilliant, no matter how smart you are, by the time you begin to talk off point, people might take you for not being serious. So ask for the agenda or course outline or course schedule of what you are presenting. If it's to be a meeting, follow the agenda. It could be a virtual meeting that the agenda has been shared. So no matter wherever you have joined the meeting from, you should follow the agenda of the meeting religiously, the way it has been presented, and not coming in with your own agenda or talking about B when when the person moderating the meeting is still on agenda A, then you go to start talking about D. So you should follow the agenda or outline or schedule of the meeting the way it has been presented. Also, speak loudly and clearly when you are speaking. No matter how good your information could be, when it's not heard loud and clear, it doesn't make any meaning. You might have the right information, might have the right message, but when people who are to receive the message, the people you are addressing to, cannot hear you loud and clearly, that message, that information doesn't make any sense to them. So when speaking, speak loudly and clearly so that people you are addressing to could hear you very well and appropriately. Also, avoid distraction. This one is one of the major problems of our present day youths. They will be in a meeting, they will be pressing their phones. That could distract you a lot. And by the time a serious point could be made concerning a patient or concerning a particular situation, because you are distracted, you won't pick it. And you go there to make a very costly mistake that might even cause the life of a patient or alter the treatment goal or plan of that patient. So for avoid distraction, our youth of these days, Nothing distract them like most, like their phone. You will see them, they're in a meeting. Some of them, they are being in the meeting is just to register their presence. They go back battling or typing what they are typing in their phone. They don't even care. Their own is just to sign in, present. I'm present in this meeting, especially when it's virtual meeting. You won't even know when serious and the critical decisions are being made in that meeting because you are being distracted. And I said earlier, the most distraction people of this generation have is their phone. Then, by my way of conclusion, technology has advanced the use of different forums to communicate and transmit information among professionals. Forums through teamwork encourages better rehabilitation outcome. Teamwork helps to share knowledge and experience among participants in a forum. Teamwork ensures continuity and the sustainability of rehabilitation and treatment. And then these are some of my references. Thank you so much. Madam Hill, I hope you are still with us to moderate if there are questions. Hello? Hello, can people hear me?
Yes,
Okay,
we
so
can.
questions,
Yes, we
if you
can.
Yes,
have
we
a
Yes,
can
question.
hear you,
Yeah,
sir.
Okay,
can hear
so
you.
let's take
Yes, sir.
questions,
We can hear
comments,
you,
and
sir. Thank you very
suggestions.
much, sir.
Yeah, so let's take questions, comments, and suggestions while we wait for Madam Ilo to take over. So I see Sunny. You have a question or suggestion. Go ahead. Najib.
Thank you. Thank you very much, sir. I'm
Okay.
very happy to be part of this forum, and
Okay.
I really congratulate you on this well uh, presented lecture. I want to. My question is on family and caregiver involvement
Okay.
in the in the rehabilitation team.
Yes.
Sometimes there might be an issue with the patient and the patient relative conflicting in
Mm.
decision making, and maybe
Issue
the
of patients and their relative having conflicting options in decision making.
yes, when decision making
Mm.
when it comes to rehabilitation needs.
Mm.
An example like a patient need a particular kind of intervention from maybe let me take example physiotherapist, but because the
Yes.
relative feel it will be part of financial loss in our own place. So they might be the one to be instigating that the physiotherapy or the occupational therapist or the surgery does not go on the way it's supposed to be likely. And this patient now is disabled. The patient cannot write or sign by himself. The patient cannot speak much. Maybe have a speech language problem. So in this aspect or in this kind of event, how do we, the health care practitioner, part of the team, how do we navigate this kind of problems? Because if you are going to make a decision for the patient because the patient agree with you, it might go against the caregivers or the relatives, their own options, and that can lead to litigation. So this is my question, sir.
Okay, thank you. If I understand you
Thank
better,
you.
you're talking about where you have a conflicting decision between the patient
Yes,
and
sir.
the caregiver or family members. And here, the patient
Yes, sir.
himself is disabled and he cannot sign to show that actually
Yes.
this is the treatment option he wants. How do we
Yes,
navigate
sir.
such a situation?
Yes, sir.
Okay, thank you. In this situation now, the patient wants this treatment as been prescribed by you as a professional, but the relatives don't want to oblige because they feel that the one's paying. You need to make every effort to convince the relative. In short, there are some relatives that are bad. Let me use that word because you might see a patient who is sick, the relative might be even wanting the person to die so that they can share the person's property if the person is wealthy. I have seen a situation
Yes,
in the
yeah.
hospital where the patient's younger brother wants the brother to die. In short, he started already selling the man's land. So in that situation, what you need to do is to get maybe the legal unit of the hospital to let them know, so that the legal unit of the hospital can guide you better, because at times the relatives of the patient might be wicked, that they want the man to die so that they will go and squander the person's property. You see them, that's why they are not obliging to that. So what you might need to do, I know every hospital has a legal unit. Complain to them, see that this is the scenario you have. So the doctor, the lawyer there can advise you the best way to go by it so that the patient can get the best treatment option, because what they are doing might not be in good faith, but to jeopardize the treatment of the man, so that the man will just go and they will continue with whatever thing they want to go do with the man's assets. So my advice in this is that consult the legal unit of the hospital. The lawyers there will tell you maybe the right processes to follow to get an enablement, so that tomorrow, if litigation sets in that you gave treatment against their wish, you have something to defend yourself, because such cases happen where you see the patient's relative or caregiver. The only reason they are not obliging is because they want the man to go away so they can do whatever thing they want to do with the man's assets.
Oh, thank you, sir.
You're welcome. Then, Mr. Suleiman, your hand is up. Go ahead.
Good morning, sir.
Good morning, my dear.
Thank you very much for this wonderful presentation.
Okay.
Mine is with respect to the rehabilitation team leader, the physician. You made mention that he examines, he assesses, he plans the treatment of the patient, the rehabilitation of the patient, sorry. And also
Yeah.
when you come to the physiotherapist on role, also he assesses, he plans, as well as render the rehabilitation of the patient. So I don't
Yeah.
know, please, I don't know if you can make further clarification in terms of, even this seems to be conflicting.
Okay.
Thank you very
Thank
much.
you. Yes. If you could recall, when we started the lectures, I said that by the time you set a goal, the rehabilitation team will have their collective goal for the patient. Then when the patient goes to see each of the professionals will now have their own goal, which will align with the collective goal of the rehabilitation team. So at the level of the rehabilitation team, most times the physician, who might be the orthopedic surgeon, is the head who will now assess it at that level. Then when the individual comes to the level of a physiotherapist as a unit or professional in that rehabilitation team, the physiotherapist will also do the assessment based on the physiotherapy point of view. They will do their own plan based on physiotherapy point of view, but their own plan or goal will align with the ultimate or collective plan or goal of the rehabilitation team, being led by, most times, as I said, orthopedic surgeon who is there. So at different units or levels or professional levels, you have your own goal, you have your own assessment, but they will all align to what the goal of to what the collective goal of the rehabilitation team is. I gave you an example that at times, take for example, a patient has come in, is the orthopedic surgeon that refers him to maybe a physiotherapy unit or occupational therapist. You might see some of them that even when you finish rendering service to them, they will go back to that orthopedic surgeon to say, to ascertain that the services they have received from you are in order. So that was what I mean by that, that even if the person meets a processes or occupational therapist, they will also do the assessment at their own professional level, do their goal, create their goal at their professional level, but it should align with the collective goal. Like the example I gave earlier, you might have an amputee who has visited the hospital for rehabilitation and reintegration. The collective goal for that amputee is to mobilize him, rehabilitate and reintegrate him into the society. At the level of the president and orthotics, their own goal will be to fabricate a befitting prosthetic limb that will rehabilitate or mobilize that patient, which aligns to the collective goal of the rehabilitation team. After that, the amputee goes to see the physiotherapist. The physiotherapist will assess the muscle strength and do the gait training for the individual. That gait training is to mobilize the patient better, which aligns with the collective or ultimate goal of that team, which is to mobilize, rehabilitate, and reintegrate the amputee. After that, the same amputee might need to go and see occupational therapist who might teach him or her how to adapt to his activities or occupation. Still, that aligns to the collective goal of the rehabilitation team. I don't think if I have done justice to your question.
Thank you very much, sir. Thank you very much. Sorry, again, in addition to this.
Yes. I'm with you.
This, what,
Suleiman, your line is breaking. I can't hear you clearly.
Hello, are you hearing me, sir?
Yes, I can hear you now. Some noise are interfering on the background. I can hear Suleiman again. Ngozi Felicia, can you go on with your own question or contribution where we wait for Suleiman to reconnect? Ngozi Felicia, can you go on with your question or comment while we wait for Suleiman to reconnect? Ngozi Felicia, you have the floor. Go on.
I have a question, sir, in case
Yes, go ahead.
nobody's asking any.
Okay.
All right, sir. Good morning, sir.
Good morning,
Good
my
morning,
dear.
fellow colleagues. Sir. Yes, I wanted to ask two questions. The first question
Yeah.
is concerning family and friends. There are times that we see where a caregiver will bring, let's say pediatric outpatient. You know, they are minors. You have to treat them with a patient relative, but you discover that sometimes the patient relative will just drop the patient and just walk away. Some will go about parabolating the hospital or just moving around or going on with their personal activities and not minding that they are supposed to be with the therapist while the treatment is being done to the patient. In that case now, will you just leave the patient there and be wasting time waiting for the patient relative to come back, or and there are other patients outside waiting for you to hurry so that they too can be treated? There was a case we had like that in Abuja, Wagwalada Teaching Hospital. The mother of the child is also a teenager, so she loved playing outside and leave the baby on the bed. We always go there for inpatient treatment, and the patient relative is not there. Will you now leave the patient because the patient relative is not there? And for how long should that continue? That's number one. Then number two, sir. Yes, number two. There are times that some other the healthcare professionals don't really respect. Let me use that word. They don't really respect other professionals. Like for instance, a physician may feel that he is almighty. Everything depends on him. When they're supposed to like give a consult to another professional, they write it on either a sheet of paper, some write inside the folder, some just say it verbally, maybe to students or nurses, go and invite this person, go and talk to this person. I've always said that that is wrong. Just like the way you fill a form for lab, do this, do this, do this test, that's the same way you should also fill for a therapist, invite physiotherapists for this and that. Now, in case some of these things are not done appropriately, what steps should you take, sir? And will you now say, okay, because you're waiting for the doctor to do the right thing, time will be gone and you will not answer the patient, for instance, the one in the ward? That's my question, sir. Thank you.
All right, thank you, my dear. I got your questions. Number one is concerning family, friends, and caregiver. At times they drop their relative or patient and go away. Will you continue to wait for them to come back before you attend to the patient? Number two, at times there are other professionals, for example, the physicians who don't respect others in their referral. They will just talk to you verbally or casually, telling you what to do for the patient. Okay, good. Your number one question concerning family, friends, and caregivers who will just dump their teenager or pediatric patient and walk away. For the sake of the patient, you treat the patient. But when the caregiver or mother comes back, you caution them. It's part of the education you need to give to them. You know, people have different training in life, and people have different level of IQ and mental power. So you might not even know the state of that person who dropped the baby and went away. Because ordinarily, a normal and sound individual, we want to wait to first get attention for the child before going for any other person. What if before the person comes back, the baby is lost? So that to tell you that that person, if you evaluate the person, you might not know what the person is passing through. The person might be having some emotional problem that even taking his or her mind away from what reality is. So you need to treat the patient. Why when the person comes back, you sit him or her down, tell the person the implications of what he or she has done. That does the person know that before he or she comes back, the baby might have been stolen? And what story would the person say? So don't say because the caregiver is not there, you won't commence the treatment. No, it's against the ethics of your job. Even if somebody brings a patient to hospital, dump the person and run away, that doesn't make you not to treat the patient. You will do. When the patient recovers or gains consciousness, you can now begin to trace the patient's relative. So whether the presence of the caregiver is there or not, so far the patient has been presented for treatment. Treat the patient. Why when the person comes back, you can now caution, advise, educate, and tell the person the implications of what he or she has done. Then on the issue of other healthcare professionals, maybe especially the physicians, not respecting others, it's all over. You know, in this Nigeria, there is unnecessary rivalry. Let me use that word, unnecessary rivalry at times among some health professionals, some feeling that they are more superior than others. It's not. Everybody is important. Besides, the healthcare services this day is multidisciplinary. So when that happens, yeah, maybe they talk to you, yeah, I should do this to the patient. Quietly go to the person. That is not the right way. That if you are too junior, maybe you have directors or deputy directors in your unit who are almost of the same level to the person, complain to them that they should talk to this oga or madam. Maybe you might be a very junior person to go and talk to him that, some people might be arrogant. They might say, who are you to talk to me? So if you have senior colleagues in your unit or department, draw their attention to it. I think they will present it better and talk to the person. And one of the ways of also trying to handle this is that when you do your own treatment, make sure you document it and put it into the patient's folder. When they tell you things by mere words, casually, or maybe just write on a sheet of paper, don't respond that way. If you do it, they will feel maybe you're irrelevant. Your own is just to touch patient, clerk the patient, do your normal assessment. Make sure you document everything you have done about that patient and put it into the patient's folder. So by the time they go through the folder, they will see that you have a written document of what you have done to that patient. It will help to pass down the knowledge in them that actually these people is not just to see patients, but there is a lot of documentation involved in what they do. Start your normal patient clerking, your assessment, your treatment plan, what you have done, next appointment, document all of them in sheet of paper. put it in the patient's folder. So by the time the man gets the folder again, he will see that you made some documentations in the patient folder. That will help to send the signal to him that you are supposed to see the person's folder and document what you have done. I don't know if any other person have anything to say on this before we move to Ngozi Felicia. Any other contribution to this or question regarding? Okay, Najib. Yeah.
Sir, well done, sir. Thank you for giving me this opportunity to speak on this issue. I think, like the hospital I work, we have what they call referral forms. And even now that we are using the digital platform for recording and assessment, sometimes we can still send the doctors or the physicians or any other professional still send consults through the DHS to your profile. So you can go to your profile or your board or your dashboard and you see referrals. This is respectful because over the years we have been doing sensitization and we have been blowing our trumpet as special healthcare professionals, and we have not been tolerating disrespectful way of sending referrals, because sometimes we do hospital presentation every year. A particular department must do a presentation for the hospital, so everyone tend to blow their trumpet, and sometimes we give more warning and cautions to those that are belittling maybe the rehabilitation other rehabilitation team. Everyone try to say their importance. So because of that, some physicians in school don't know about maybe physiotherapy or nutrition, and because of this, they'll think everything is all about medication or everything is all about surgery. But when you during hospital presentation, you tend to sound your trumpet. You tend to tell the world this is what we do, and it is objective, it is clinical, and it is based on knowledge and evidence based. So in this, there will not be any disrespect, and there are some particular specialties that actually know what physiotherapy is like. Most of neurologists now or neurosurgery and pediatrics, even geriatrics, they understand physiotherapy is more important. But when it comes to people like the orthopedic surgeons, this one we know the surgical aspect that are, sorry to say, some of them are arrogant. They still disrespect, despite knowing what physiotherapy is important in rehabilitation and maybe occupational therapists, they still tend to be disrespectful when it comes to sending a consult. They might decide to say it verbally, and so sometimes our like my head of the department will like reject this consult, or respectfully send them another consult that this is not, don't tell us the way to handle the patient. Just send, like if I want to send I want to send a referral to a neurologist. Say, sir, I've been seeing patients for so, and he start complaining of so headache that is not relieving. Please do assist this patient with assessment and treatment. I'm not telling the neurologist what to do. I'm actually telling them to help the patient. But because of that, there's mutual respect between us. So I think if the hospital, that lady, this colleague of ours work, if they don't have referral platforms that is formal, it will be causing this kind of problem. But if there's referral, a formal
We
referral,
do. Sorry, I'm coming in. We do. In fact, I had
yes, sir.
I did a presentation on the role of physiotherapy in healthcare team. I did that. And we explained these things categorically. The CMD was there, the CMAC was there, even the HOD record was there. We asked him, do they have this consult? Because it's only NHIS that have moved to digital. The other the manual, just moving with folder and other things like that. We asked them, do they have this referral sheet in the word? They said yes, it's there. So what I did was that anytime they bring a patient with a written note or something inside the folder, like
Yes.
treat this person, I tell them, who is the doctor still in the ward? They will say yes. I said, take it back to him and tell him to fill a referral form, fill a consult. But then I will still talk to the patient relative, because I wouldn't stop their treatment because of
Yes.
the doctor's misbehavior. You understand? Or lack of respect. So it's not that they don't know what to do, they just refuse to do it. You understand my point, sir?
Yes,
Thank you
yes,
so
thank you. I think your point is taken. I know is individual differences. Some people
Yes,
might
sir.
choose
Thank
to
you, sir.
be arrogant, while some will choose to do the right thing. But whichever way, just politely talk to them. And as I said, if you have senior colleagues, you have people in the directorate cadre in your unit, bring this to their notice. Let them engage those people that are doing, because this every treatment given to patients should be documented. When you finish your own case, refer to the next unit. They document what they have done. Okay, this thing they tell you orally or casual, they go and do this. Do they know whether you have done it or not? No. So it's good they do the normal thing. So actually, is on individual differences. I know some people are like that, why some are not like that. So, but whichever way, try to fashion out a way to follow them. Don't say because they didn't do this, the patients will suffer. No. There is a saying that where two elephants fight, the grasses will suffer. Don't suffer the patients because of the attitude of the physician there, but look for a way to bring it to their attention. And as I said, even when they write on piece of paper, whatever, document what you have done. Put it in patient's folder. So by the next time they're going through that folder, they will see that you are making input, a reasonable one, to the patient's treatment. Thank you. So Ngozi Felicia, your hand has been up. So say what you want to say. Ngozi, we can hear from you. Any other person that has
Hello, my hand is up. I don't know if I could be allowed.
Okay, go ahead.
This is Gordons. Thank you for the opportunity to speak. One of
Yes,
my colleagues has spoken already, but just an advice for the lady in question, talking about the clashes in referral protocols and all of that. She should
yes.
she should explain, just like you said, she should explain to her head of department and let her head of department take it up from there. And then it's not a one-day thing. It's not a one-day thing. Sometimes the war method is better. Sometimes the diplomatic method is better. So the head will know which method to use depending on the temperament of the physician in question. That's my advice. But it's a continuous thing. Just like you said, documentation will help. Prove what you know, do what you are supposed to do, and then continue the engagement process. Sometimes most of the time, they understand. But that feeling of who are you to come and talk, sometimes is always there, but there's always a way. We use wisdom to go around it. We had it long ago and we settled it in our own institution, and it has never ever happened again. Thank you.
Thank you so much for such wonderful contribution. Yes. Any other question or contributions? Any other question or contributions? Okay, in the absence of any other question or contributions, I want to thank everybody once again for creating out time to be part of this interaction. Thank you for your time. I don't know whether Mrs. Hill is here so that she will guide us. If we are continuing immediately with Dr. Bankole to continue with his own side of the presentation, or we're having a break. Sorry, 1 minute. Let me contact her to know what her directive are. 1 minute. Hello, I just got Mrs. Ile. So she said Dr. Usman Bankole should start up his presentation immediately. So, Dr. Usman, if you are with us, can you take over?
Hello, can you hear me?
Yes, we can hear you. Good afternoon, Doc. We can hear
Hey,
you.
good afternoon. Yeah, good afternoon, everyone. Can you also see my screen just to make sure, please?
Yes, we can. We can.
All right, with the slides.
We can. We can see the slides.
All right. Okay, that's good. So, good afternoon, everyone. Thank you for having me. It's really, yeah. Is someone wanting to speak? Um, yeah, so if you have a question, you can raise up your hand, and that will be easy for us, I think. And we could maintain that tradition for the next couple of minutes while I finish the talk. So it's an honor being here. I really appreciate the opportunity to get to speak with you again and to wrap up on what Dr. Tochku has mentioned, has explained for the past 2 hours. So he has, if you listen carefully, he has talked upon who are the team members, what are the stakes if we don't really participate in this information sharing platform, which we call Teams Forum. You could make it in a different way. It could be face to face. It could be via virtual technology. It could be emails. It could be so many ways that we use communication in day-to-day clinical activity. So what I would like to talk about is to really add on what he has explained, and that is the strategies for effective communication in rehabilitation team. In essence, what exactly does it take to really pass your information so that other team members could really understand what you want from them and what you need them to do. So if you listen to the argument between Najib and, I mean, the conversation raised, the argument raised by Najib and Inyang, it's a matter of communication. I mean, it's just a friction where the information has not been really passed on, and the individual differences we do have, like what Gordon was saying, when two elephant fights, the grasshopper. So when we have this kind of conflict in most cases, is the patient that suffer, right? So what I'm trying to say in this talk is that what do we need to do really to make sure that we have this effective communication in rehabilitation team and also across other teams? So I would kind of quickly take us through 4 things, and it would be great if you could grab this in the next couple of minutes. And this include, I want us to have this clear understanding of what effective information sharing is in Teams Forum, and how do we address specific challenges in interdisciplinary rehabilitation teams? How do we mitigate those problems and avoid them from happening? Because sometimes the damage, when it's done, it takes a lot of effort to repair it. And the third thing I want to bring forward is some ethical and legal considerations, especially in Nigerian context, on how do we share this information? Because it's not just sharing information, we are sharing someone's privacy who has entrusted us with he or she has uh, medical problems. So this information that we share amongst us has a lot of stakes in it, someone's life, someone's privacy. So how do we share this? Especially the fact that the world is becoming more digital nowadays. We use so many platforms. 10, 15 years back, hardly do we use any specific technology, even in advanced places, uh, or to kind of communicate patient information. But nowadays, people even use WhatsApp to just tell you. So we use communication tools that are in our pocket in everyday life to share information. So how do we do that safely to make sure we are within the ethical and legal boundaries without overdoing? And then I would share with us the strategies and the tools that we need to improve communication in whatever way we choose to do it in our day-to-day clinical practice. So Here is a situation, and I want you to listen carefully. It's just the same thing as what Najib has take on what the lady Nyangwa. If I apology if I didn't pronounce your name clearly, I was just listening.
Nyangwa, or you can just call me Asama.
Okay, Asma. So if I listen to you carefully, so it's an issue of communication, right? So think of it that you have a clinical meeting. It could be within rehabilitation team, but it could be a hospital meeting itself where you have case presentations. Like I think someone mentioned they do that annually for each department. I think it's Najib. So think of that. You have a patient called Mr. Abdul. He's 60 years old. He has mobility issues. And the main problem is he also have a mild speech impairment. So you have this patient and you want to present to the team. And I have three approaches for you here. The first one is a very sharp, clear, structured way that we normally write patient anamnesis or fill out patient forms, right? So here you have the first one, which is you have a clear situation. What is the problem? Mr. Abdul is 60 years old. He has 6 weeks post-stroke. And then he has a new challenge, which is his balance is problematic. And he also attempted to fall 2 times during therapy session. But the background problem of Mr. Abdul is that he's right-sided hemiplegic. He walks about 50 meters distance with a cane, quad cane, and his BP is stable. But he has recently been placed on a new sedative at night for insomnia. So the assessment of Mr. Abdul is just right-sided limb weakness, which have decreased from 4 to 5. Think of it in any scale that you want to, but this is an example. And he has dizziness in the morning. His cognition is intact, so he knows people very well around him and the environment. But you suspect that there's a possible medication side effect, and also his ear might be the issue causing him to fall. But when you walked into this meeting and presented this case, being in a form or the way I just said it right now, you wanted actually the people, the clinicians around you, to get this message. You want them to post the sedative, whoever it is that was prescribing the sedative, let's say Dr. Obi, and you want to tell them that right now you give Mr. Abdul a gait belt so that he doesn't fall. And you want the OT in the team to have a safety check, probably going to his home and check the kind of environment he's living. And then you want the physician who prescribed the insomnia medication to review the medication. And possibly you want the patient to be referred to ENT because it could be an ear problem that is causing him the dizziness, maybe vertigo or vestibulopathy. So this is approach 1, and that is how I said it. But if I want to take approach 2, for example, I say, in a story waveform. So last week I have Mr. Abdul, who was confidently walking 5 meters with his cane, but over the past few days, something has changed. He stumbled twice in therapy, and he feels dizzy in the mornings. His wife was also noticed. He seems very groggy or wobbly. Then test shows that his leg is weaker, and I realized he was started on a sedative at night. I'm worried about his safety. I'm already using Get Belt to prevent fall, but I would like your input. So, Dr. Obi, could we review his medication? And Kemi, who is the OT now, a home safety visit might help. And if needed, maybe ENT can check his inner ear problem if he has inner ear problems. So for now, the priority is keeping him safe while we work this out. The last approach is, I say, last week, Mr. Abdul was confidently walking 5 meters with his cane, and his wife was thrilled. She is happy. But in the past few days, something changed. He nearly fell twice in therapy, and now he feels dizzy in the morning. He has right-sided weakness or hemiplegia, to make it simple. And until now, he had been stable. He was recently started on sedative at night. Today, his right limb strength has slipped a grade from 4/5 to 3/5, and he seems dizzy. I suspect the medication may be playing a role, but the inner ear issue isn't ruled out yet. So for now, I'm using Get Belt for all mobility. And Dr. Abi, could you review his meds? Kemi, maybe a home safety visit, and if needed, we could involve ENT. So that is where we are. What do you all think in this is the safest next step for him? I mean, Mr. Abdul. So these are three ways I could approach this, right? When I speak with people, my colleagues, rehabilitation team, or involving any other healthcare professional in the team, you could see what it looks like. So the first situation, which is approach one, I have a clear structure format, which everyone in the team is aware of. That's how we write clinical notes. What is exactly happening right now? That is the immediate issue, right? The balance problem. Then secondly, it's very clear with the background. What is the context? What is the medical history of Mr. Abdul that the team need to know? And then third, the assessment. What do I think is going on, which is my clinical judgment? And the last one, R, is what do I suggest for the team to do? That is exactly what I want them to do. Very clear. So this is very strong, right? And it is strong because it is very standard. That's how we all write our clinical notes. Everyone knows it. And it's also very concise. So I'm not overloading them with information. I strip out all irrelevant information and it gets to the point very fast. And it is safety focused because that is exactly what I'm attending. I'm trying to reduce the risk of missing critical details. So everything about the patient, it's in here in this short narrative. And any healthcare professional from any country, from anywhere, could easily understand what exactly is the problem. So this is a format that we all get used to. But here's the problem with this, right? It sounds really mechanical and flat. So it feels like I'm reading a form. It's not live patient problem. Like it's just reading a form. And it doesn't exactly capture the patient's story, the emotions of the patient, or the family context, which in all the things you have just discussed with Dr. Tochku, you see play a very important role because sometimes people tend to have their own perspective, which might conflict the actual reality of the patient or you as a person responsible for the patient at that moment. So it kind of limits the conversation and it's more of like reporting and then engaging. That's one way or two-way military approach, like just direct without any emotions or personal connection. The second one, which is approach two, it started very well because it's baseline. I gave the patient journey so far, and I exactly said what changed, which is the issue of falling for the patient. And then the conversation is really observational. There's a kind of patient voice. I tend to put what his wife said, what was the things around him, and what people were saying that are connected to him. But then also I maintained some clinical insight because what I put there as my assessment. But then I ended up very well by putting my worries, which is I'm trying to keep him safe for now, but this is what I want other team members to do. So it's in a way very strong because it feels real, it feels human, it feels memorable, and it is patient-centered because I put the patient voice inside there. And it builds empathy across the team because all the team members now understand what is needed from them compared to what is in the first one, right? And it opens the floor for normal discussion. The problem is that it can drift. And what I mean by that, it can ramble. You can go all direction. You can begin to tell stories which are not relevant to that meeting. People will get bored because it's not what really concerned them. And then the risk of missing clinical information, because the more you go into that storytelling thing, you might easily begin to miss the clinical details. And then because we are all trained to be focused and clinically oriented, whenever someone is speaking, we try to find the clinical relevant information from what they're saying, not the other noise, because that's what we need for making decision. And then if everyone would want to do this, it is possible that everyone has his own way of seeing the problem. Someone might just start by seeing the problem before he goes into the main clinical assessment. Someone might start with the clinical assessment before he goes into the main problem. So it becomes very messy sometimes, and it is really time consuming. You can't control it, right? So you can see each one has its strength, it has its own weakness. Then the third one is, it is really narrative. If you look at it carefully, it exactly kind of says the patient journey, but then I also take what is informed in approach one. It is very structured. I kind of say what exactly is the situation, what is the background, what is the assessment, and what exactly do I want the people listening to me to do in that clinical meeting. And it is collaborative because I kind of end up by saying, what do they think? So I'm not imposing my perspective or my clinical judgment on any other person in the room, while because we all tend to attend to different patient problem. So I am opening the floor by being down to earth and asking anyone to contribute to patient safety, right? So this is also strong because if you look at it, it is structured and also engaging, but then it's also include patient voice into it. So it's not just flat formed kind of thing, but it's kind of staying safe and also precise. It has the clinical note. If you look at the assessment I have in approach 1, is also in approach 3. And it is flexible. It works for teams, rehabilitation team, and you can also use it in emergency cases. In A&E, for example, you can easily explain this within a minute, and whoever there can understand what the problem is. And then that builds trust because in a way, the team feels both informed and also involved. But the problem with this is it requires skill. It is not natural for everyone to combine the real human aspect of you with the real clinical training we had to really engage in day-to-day clinical activity and conversations. And it is balanced in a tricky, I mean, the balance is tricky. It is risks of leaning too much into storytelling and then you miss the structure, or too much into structure and then you miss the human element. And it needs you to prepare very well in advance. So you can't just improvise it while you go into the meeting. You have to have it well prepared before you go into the meeting. So my question to you now is, tell me, and I want you to put this in the chat. If you are the person presenting this patient case, which approach will you take? Approach 1, approach 2, approach 3, or which combination of the approaches? So if you say approach 1, type 1. If you say approach 2, type 2. If you say approach 3, type 3. If you want to combine any other thing, just type 4. You can put that in the chat. And the first person that gets the right answer would have a gift of mobile data. I can see 1, I can see 3. I can see 2, I can see 3. I can see 1, I can see 3. I can see 1. Remember, 1, 2, 3, or if you want to combine any of the 3, write 4. The first person that gets it will get a mobile data gift. 1 and 2. I will change my mind. 4. One, Najib 1. Olawami, you said you changed your mind to 4. Okay. One and 2. Abdullah, 1 and 2. Four, Abdullah Khalid. All right, that's great. Khalid 1. All right, so I'll be a little bit generous. I've changed from 1 person to 3 winners. So the first 3 people that answer 4 get the mobile data, and that is Abdullah, Olawami, and Chidera. So you guys, please drop your email or phone number with Miss Tolupe, the MRTB, and I will send your gift to them, so you can have it. All right. So that is That is correct. There is no right or wrong answer, to be honest, but you can choose for yourself. The main answer is the combination, because if you take one, you can see that you I've already mentioned the problem with one. It's too rigid. You lose the human contact in it. And the problem with Dr. Tochko has explained is that human touch in it, right? When we communicate, we have to have that human touch. That is what keeps us connected. You need to know who you're talking to, what is the mode of communication of that person. I mean, how does he prefer to be communicated to? And then you can communicate with everyone effectively, right? So it's not a one size fit all. I'll explain what I mean by that later. So if you take two, you see the problem is two storytelling. You are not telling me anything. It's just normal narrative. It's just the way you're telling a friend. You're not telling me as a clinician. If you go with three, it's a little bit much better. But if you give me three in a clinical meeting, I cannot take it because I need to see the structured format before the meeting. Or even at the meeting, I need to have a written format, which I'm used to, and then I can connect with you when you speak in four, right? In approach three, right? So that is what I'm trying to explain here. So for those that I say four, you're right. And my key takeaway message, if you want to take just one message out of this, is that in our rehabilitation team meetings, the best presenters are storytellers who are also structured. They bring that patient alive, but they never lose the precision in the teams. The team needs to act. So you tell the story, you give the actual story, the structure every clinician is used to, and you kind of never lose the precision that the team needs to act. You're calling them to action, right? So keep the structure, add the story, blend the two approaches, be clear and human, engage with the team, and build the trust, and better decision will be made. So don't choose, but blend structure with story for the effective rehabilitation communication. So that's my key message here for you. If you had to take one thing, that's what I want you to take. And then for the structure, there's something called SBAR, and that is being used to put out structure in what you present in clinical meetings, right? So the first thing first, because you are not interacting with intent, you're interacting with clinicians who you want them to act on a specific problem, like the situation we're talking about now. So you're not teaching, but you want action. You're calling for action, right? So in this case, the first thing is, what is exactly do you want? That's the situation. You have to communicate that as clear as possible. And who are you communicating with, right? So you need to identify that self and side. You need to know the person you're calling from. And then you need to identify the individual. Precisely, that's in the meeting. Who am I looking for and for what? In this situation of Mr. Abdul, I want ENT referral. I want the medication that was prescribed for insomnia to be reviewed. And I want home visit for safety checks. And I started clearly in the beginning that Mr. Abdul has been doing well. The main problem is he has now balance issue. He even attempted to fall twice. So for everyone in the meeting, that's very clear. This is why we're here. So the situation has to be as clear as possible before you even jump into the clinical jargon, before you begin to talk about the clinical assessment or whatever it is. That comes afterward, right? So when you give the situation, that is when you would then jump into the background. So who is that patient, right? So you need to be very precise here. What date and time, if it is admission, what is the admitting diagnosis, what are the relevant medical history, what are the lab or diagnostic results, and what are the notable changes over time that you have been seeing the patient. Then after you do that, you move on to the suspected underlying cause. And that's when I presented, if you remember the case of Mr. Abdul, the underlying cause, I am suspecting it to be the medication or vestibulopathy, as clear as this. So anyone who is charged with responsibility for medication prescription or vestibular problem would know exactly I'm calling he or she to action, right? So I'm now given my underlying suspected cause of the problem. This is not necessarily my own assessment of the physical limitation of the patient, but the physical limitation of the patient relating to the situation I explained in the beginning, which is the situation and the background of the patient, to put it into context. And then I am closing the talk by recommending So I am recommending my own expectations, what is very clear and specific, and what is the urgency of my request, and what is the expected time frame. So if you don't give people that, you allow them to wander around, right? So you have to be very clear on your expectations. What are you bringing forward? You're not imposing, but you as a responsible clinician have this responsibility of making sure your patient problem is passed across to everyone on board, so that they know and what they need to act on. So the recommendation is very, very important. In essence, what I'm trying to say here is the purpose is just to give you a communication tool that you can structure your conversation for any medical situation. And if you want a kind of immediate attention or action to be taken. And of course, this kind of reduce errors, right? Because you are very precise and human as well. And then it encourages assessment and decision making skills. It reduces error because you are very precise in your communication. It encourages assessment and kind of decision making because you are being human. We all have differences. The way we talk, the way we engage with people, the way we want people to talk to us, the way we want people to engage with us. So it's a combination of the two worlds to make it really work in any situation, rural, urban, any kind of situation. So I'm not going to take much time here. We've already heard from Dr. Tochukwu um, what a rehabilitation team consists of. You all know this, of course. It's just to show you that again, we're not alone, right? You're not alone. You're part of a team. You function as a complex system in which everyone is contributing to that same patient, for example. So that means we have to actually communicate. And if you look at it carefully, all these specializations do have their own doctrine of training that they had. So the way a nutritionist was trained, it is somewhat different from the way a cardiorespiratory physiotherapist is trained, right? So we have this dogma that we have as name, but also at the bottom, the underlying doctrine that we have been trained on is somewhat different. So the communication style, the engagement style really differs. So that's why it is very important to recognize your position and to know how to interact with everyone in that complex system. So for effective communication, here are 11 tips I would like to give us. So we shouldn't shut people down. That is what I mean by saying say yes and. So when someone makes contribution, we need to listen, agree, not to say that it's correct or wrong, to agree that we have understood the basics of where that person is coming from, and we say our counter argument for or against what the person is saying or contributing on top of what that person says. So that way, it's not a battle issue. It's about cordial and collaborative effort to make the patient's life better. That it's not a game of who is right or wrong, but it's a game of complementing each other's strength and weakness. Then we need to really define roles and goals clearly. So who is doing what? That is very clear, right? From the dogma of our needs, we know exactly for each profession who does what, right? So in every meeting, that also has to be acknowledged who does what. Because if the issue is presented properly, it becomes very clear because rules are very clearly defined. And we need to learn how to communicate with people because people kind of like to be communicated the way they expect it. So it's not a matter of one size fit all, like I said. Some people like to have physical meetings, some people like to have emails, some people like to have Teams meeting. Everyone has a specific way that he or she functions very well when it comes to communication. So we need to identify that and work with that to make sure the environment is safe for the patient. So we need to embrace two-way communication system as well. So it's not just straight jacket one thing that you say thing and that is it. You have to expect feedbacks. You have to expect criticisms because no one is perfect, right? You have to expect feedback from people for or against what you say. And you have to really acknowledge that rather than staying on your stance and not willing to change. So that's also very important. And we have to be clear about our mission, right? So whenever you go into meetings, the mission has to be very clear. I'll explain what that means in the next slide. But why are we in the first place having this meeting? That has to be very clear. And any counter arguments back and forth, which we do in clinical meetings, have to be on that focus, not on a private or personal basis. So whatever argument you're bringing up, it has to be really in the interest of the patient. not your professional rivalry or whatever it is. That way, you have the leadership role when you communicate. And then also, you have to have open door policy, right? Not necessarily that the meeting has to be with the same people that have been invited. It should be open in a way that people can walk in into the meeting, and you don't have to impose a strict deadline or things like that on people. That makes it much easier. And again, I want to emphasize is know your people. So know the people you work with, know the other departments, who are they and how do they prefer to be communicated to. And don't kind of forget about fun, right? I know we will get lost in our clinical day-to-day kind of job. We get tired, we get exhausted, and we are not interested in anything else. Sometimes that human touch, that humility makes a long way to, I mean, it takes a long, I mean, it contributes a lot to, for you to get someone do what you want that person to do. Be it referring the patient, you want the person to see that person, to see the patient again, or be you sending back the patient for some review of medication or something like that. And you have to kind of be intentional. What that means is be very, very present whenever you communicate. And you need to leverage technology, right? Sometimes face-to-face meeting works, but leveraging technology, it also helps sometimes. So why do we need to do this, all this effort, right? And the purpose is really to share treatment progress and to kind of understand, enhance our interdisciplinary understanding within teams, right? So we want to foster team cohesion. It could be one of this, or it could be both of this. In an emergency situation or in a clinical case presentation, in most cases, we want to share patient treatment progress or even mortality review. Who knows? So it really contributes to the entire ecosystem of rehabilitation. And the main goal for information sharing, the entire end game, is to really facilitate better patient outcome, right? We don't just have meetings to for the sake of having meetings, but we want to improve our patient's outcome. That's why we have this meeting. So it should be the main primary goal of every meeting. And then we want to promote transparency and accountability. The back and forth that we just had from Najib and the other Asmara, it's about promoting accountability and transparency. So that's the goal of sharing the information. You want the patient care to be transparent, but you want to be accountable as well. Then you want to build trust, because only with trust and respect among the team members, that is when the goal of the entire Teams Forum succeed, which is the patient outcome or sharing patient strategy or whatever 3 items that I mentioned earlier can be achieved. So I mentioned differences in people and differences across team because of the individual difference we had, but also because of the doctrine that we had during training. We tend to have different differences. But to put this into perspective, in the first place, why should we arrange a meeting? Why? That's the key question, right? Why do we need to arrange a meeting in the first place? So to arrange meetings, we need to kind of think about what time of meeting do we arrange. Are we arranging a meeting to share information for us, or kind of get feedback, or kind of update ourselves on patient progress? Or are we arranging meetings to brainstorm some idea, perhaps how to restructure a department, how to plan certain things within department, how to generate ideas on how to do things better? Or are we there to solve problem specific to a patient? Or is this meeting actually to build a relationship? A lot of this have been said during the course of the question and answer you had with Dr. Tochukwu, which is about building relationship, right? So you need to choose exactly what is the purpose of the meeting, what type of meeting we're trying to have. So if it is yes, you want to share information or you want to update about patient progress, how is it? Is it a sensitive information or complicated one? If it is not sensitive, to save everyone time, you can write a note, be it an email, be it on the patient case file, and send it to the other group or to the other clinician. That saves a lot of time, right? But if it is a sensitive information and it is a complicated one that you need to engage one-on-one, then you can arrange a meeting. And that include the broader aspect of entirely structuring a department or a specific project of getting equipment in the department, or it's about generating better ways of attending to in or outpatient, or is it about problem solving that is specifically patient case problem? So then we need to be clear on the purpose. Is the purpose very clear? Are we clear? In the case of Mr. Abdul, the purpose is very clear. Mr. Abdul has been doing well, but all of a sudden, Mr. Abdul is dropping. He is even falling twice during rehabilitation process. So this is very clear, right? So if it is very clear, you need to arrange the information. If it is not clear, don't go ahead and schedule broader meeting. Engage with the person one-on-one, because then you tend to understand the problem more clear, right? So if it is not clear, then you need to schedule personal time meeting with that specific person. That works better. But if it is very clear for everyone in the team, and we are talking about case report in this case, then you can arrange a meeting. And that helps a lot because it strengthens the bond between the teams, but also it strengthens the outcome of the meeting. So this is just a kind of anatomy of why do we need meetings, and why do we engage in them, and how to plan them properly. So to I don't know, someone has taken control of the screen, and he or she is drawing, I think. Well, anyway, so to look at the context of a meeting properly, there are a lot of things involved. First is the room, the facility, the time resources, the service model. Is it in and outpatient service? Is the staff resources, and the alternatives and other available services around the context of that specific meeting. So meeting input, mediating process, meeting output, meeting structure, team and social climate, and future of a successful meeting. So if we are talking about team input, meeting input, so that is the personal contribution that is given during the meeting. And that is about we, the people attending the meeting, the clinical report, the departmental meeting, or whatever name we kind of give it. And that requires personal presence. Personal could be virtually, it could be face-to-face. And then preparation. We need to have a proper preparation of the meeting. So we need to prepare in advance. That is the form of the approach one I shared in the case of Mr. Abdul, right? So we need to know about the patient history. We need to know the current capacity. We need to know the performance, the barriers, and the facilitators. We need to be very sure on the active and goal-oriented contribution we want to give in that meeting. So knowing beforehand helps team members, or giving time for team members during a meeting to kind of digest the patient case file in a summaristic way that I showed really helps a lot for them to contribute meaningfully, right? And then the meeting structure, it has to have a specific agenda. It has to have specific documentation, someone taking note of what has happened during the meeting, and it has to have a standardized assessment tool. Have progress been made or not? And that ensures tracking of the meetings that are being taking place clinically to see if there is any meaningful outcome from those meetings. And then the goal setting and action planning should be very clear as well. And then the leadership helps a lot in the mediating process. So who is chairing the meeting? And what is the nature of the talk, the accuracy? And what is the leadership style? Is it the head of the department? Is it the CMD? Is it who is taking? Is it the chief intern? Who is chairing the leadership of the meeting? And then the power relationships. So how does the power culture applies to your clinical hospital? I mean, the clinical situation you work in. Is it always the case that intern will begin to speak before the top guys, or is it the top guy that always start first and it goes down? Knowing that really helps, because each specific hospital or department do have their culture in terms of mediation process. Then team versus social climate. Is the meeting specifically a professional one, or is it a patient-focused one? In the case of professional, it could be relationship building, say between Department of Cardiology and Department and the cardiorespiratory physiotherapy unit, for example. Or it could be patient-focused, like in the case of Mr. Abdul, where we will actually want to discuss a specific patient case. And then, is it about role? Is it about knowing who does what? Is it about creating good atmosphere? And is it about team interaction and interpersonal relationship? So the output of every meeting normally falls within the 6 point. Is it information exchange? Do we have this meeting to really exchange information? Or do we have this meeting to monitor a progress of a patient? And then is it about deciding, taking a decisive role in the meeting to kind of draw a line of action? Or is it action plans agreed? Do we agree on a specific task to be done? And then is the goal being reviewed? Has the goal in the previous meeting been achieved? Has the actions been allocated? Does the ENT get to refer Mr. Abdul? Does Kemi get to review the safety of Mr. Abdul? Dr. Obi gets to review that insomnia medication he prescribed for Mr. Abdul. So these are the kind of things that are action allocated, right? So the output of a meeting falls within the six output. So you need to always have this at the back of your mind. At the end of the meeting, has the goal been achieved or not? If the aim has not been achieved, then the entire meeting is a waste of time and effort, right? Then when a meeting is successful, normally it has these five futures, one or all of them. So it is either comprehensive and holistic, all the set out goal from the agenda has been done, the objective and relevance. So the objective of the meeting has been met and the meeting is relevant. And is it patient focused? And is it respectful? And is it timely and accurate? If you set meeting to be 9 to 10, it should be 9 to 10. It shouldn't exit 10 o'clock. Otherwise, you're intruding into the people's time, right? So it has to be time and accurately respected. And then is it concise and consistent? So we don't get to sit in a meeting and begin to talk about your family because the meeting is specifically on the patient. We don't get to sit to discuss patient problem and then we get to speak about your last holiday. So a successful meeting has to be this consistent and concise, straight to the point. And then the benefit of online forums. Of course, we are used to face, but these days there is a lot of blended approach, right? Even in the clinical practice itself, we have something called telemedicine, telerehabilitation. It's no more all in face to face. So there's always benefit of this online forum. And one of them is there's kind of depth of discussion and that kind of allow reflective process. So because there is a distance, but we are still online, it allows this person to kind of reflect rather than react to what I say all the time. And then it fosters collaboration because distance doesn't matter anymore. If your patient is in the rural area of, say, Sokoto or maybe in Abia State, you can still attend to that patient if you are in Abuja, for example. And then the record of information also helps because the tools have transcription tools. Because if your patient cannot speak English, for example, an online platform can translate your English conversation into Hausa, for example, or translate it in real time into Yoruba or into Igbo or into Ababio for that patient to listen in his own language in real time. So this is one of the benefit, right? And then there is this visualization of interaction. So it identifies who is active or passive during that meeting. That's also another feature. But all these benefit comes with challenges, right? And one of the challenge is a structural issue. I might be used to having meetings on Zoom, but another person will prefer to have WhatsApp call, right? So that's another difference is that problem that comes with it. The interface design, the hierarchical navigation, and the limited visualization too. If I interact with you physically, I can do a lot of assessment, which if you're online, if the patient is online, I can't do that, right? I can't do that. So there is also engagement barrier. Some teams get to be more motivated if they're physically seeing you, while the clinicians tend to resist adaptation of new tools. This happens a lot. You have a new technology, and then physiotherapists or OTs don't want to use it, for example. They might have their own prejudice about it, but they resist new development. We tend to have, as clinicians, sometimes resistant to something that we feel is a threat to our expertise. So there is also this case in digital platforms as well. So we need to have that at the back of our mind. So specific to physiotherapy challenges, communicating technical terms to non-specialists. If you look at the case of Mr. Abdul that I explained, I have not been too keen on putting our own technical jargons into it, right? A nutritionist can easily understand what I said about Mr. Abdul. Even a hospital porter can understand what I actually said about Mr. Abdul, right? And likewise, even a cardiologist or cardiac thoracic surgeon, I can also understand what I see. So the method of communication really matters. You need to have to simplify what you say, even though you want to go to the extreme of using your technical jargons. Sometimes that doesn't help, right? So balancing the input with other roles. So that I've said in the previous slide, and also encourage people to participate during meetings. So strategies for effective presentation when you want to make clear hospital presentation is you need to prepare very well, understand the audience, right? Like what Najib said, they used to have ground hospital annual meeting. Expect in that kind of meeting, you expect even the hospital porter to be there, right? And perhaps the same patient you're discussing, he might be the one that has ported the patient all around the hospital, from the theater to the ward to the outpatient. But if you speak in technical jargon that much, he doesn't even know who you're talking about, right? And maybe he has played a great role, like Dr. Tochuku said. You might think they're not relevant, but they play a great role in influencing your own treatment. You might be the best clinician, but they can easily, with simple words, alter your own expertise, alter the patient belief, right? So you need to talk very clear and well articulated when you make clinical presentations. So you need to prioritize relevant information. Some informations are just noise; they're all jargon because um, it doesn't benefit anyone. It's important to you, but it's not important to the audience. So during preparation stage, you have to be very clear on what exactly is useful to the people listening to me. And then you have to really embrace the culture of being clear and being having brevity. So you don't have to go to talk about the entire story, but try to avoid jargons and make it very, very concise. And then use interactive sessions, question feedback during meetings to really help. Sorry. So the objective needs to be very clear, who is doing what, and then you need to adapt to the team members. And then the meeting has to have some engagement techniques. Address team members by their contribution. Use diagrams or patient assessment result that makes it really live. And then uh, yeah, someone is tampering with the screen. Could you stop that, please? And then the etiquette of teams, of team forums. Communication has to be in a respectful way. You need to acknowledge everyone's input. That is what I meant by saying yes and rather than saying but, because some people, when you choose the word but, it's just they just go into self-defense mode, right? Even if you have the best answer, they would never listen to you because of that word but. So you need to choose your word carefully because the interest is the patient, not your own, not the other person's interest. So choice of what really matters when you enter into conversations with people. So I'm not repeating what Dr. Tochiko has already said, but just to re-emphasize, when you have meetings, um, you need to be punctual. You need to come prepared. You need to speak clearly. You need to actively listen to people, right? You need to actively listen to people because words carry a lot of meaning. So you need to give other people opportunity to speak, and you need to follow agendas of the meeting. That keeps it very clear. People will be interested to contribute. And then you need to ask clarifying questions. Do not assume. Ask questions. Be clear. Be on the same page. That really avoids any conflict. And then be attentive to body language. Some people don't speak much, but their body language tells 1,000 words about what they intend or what is going on in their mind. So that is very, very important. And then when we use technology, here is my word. Only use technologies for team forums approved by your organization. And that's very important because we are not in a marketplace, right? We are not Amazon, right? So we are talking about patients' life. So we don't take to use technology that is not well approved, and then we share patient information on that. Data is very important. Data is very important. You don't just get to share information on every platform. It is very risky. So you have to choose what meetings platform to choose when a virtual meeting is necessary with other people, right? And then do not record meetings in clinical settings uh, anyhow because of the sensitivity. It could land someone into legal problems, right? You're talking about patient privacy, you're talking about patient's life. So it's very risky. So avoid recording clinical meetings per se, only if it is necessary. Then create a positive environment for inclusivity. I've already mentioned this. Respect everyone and address conflict. Monitor feedback. How do people respond during the meeting? Who is contributing and who is not? And take note of that. Then you really need to integrate workflows. That is the assessment of meetings, like I showed in the previous slide, to really understand what is working well in that specific context of a meeting, and then update people with feedback about minutes of the meeting, what has been agreed, and what needs to be done and by whom. Then you need to update people about patient progress. So it's not just about the patient notes that are relevant at that specific moment. In some cases, we need to go further to explain what is being done in physiotherapy, for example, or what is being done in occupational therapy, or what is being done in nutrition, so that other team members could kind of reason with that and plan their own treatment of action in line with what you're doing. So when you do meetings online, you need to break out decisions to analyze forum dynamics. So when you have many people in the meeting, sometimes it get very hard to really analyze what is being discussed. So having breakout really helps a lot. So just to wrap up, here are some statistics for 2025 about using technology, especially Zoom. What works best, worst days to make meetings are normally Mondays and Fridays. These are the worst days you could organize virtual meetings with people. And the best day to organize a virtual meeting is on Tuesday. But people tend to prefer having meeting in the morning or right after lunch in the afternoon. And fewer than 10 people is normally ideal for a meeting. And then online meetings were kind of about 46% last year. And then here is the most popular multitasking people do during meeting. If you do meeting people with people virtually, sometimes they do other things. You might think that they are looking into the camera, looking at you, but they're actually doing other things. They could be doing emails. They could be sending text messages. They could be browsing through social media. Dr. Tochko has mentioned this, especially with Gen Z, right? So you'd have to be cognizant of that. Otherwise, the meeting will be a failure. And then people tend to feel pressure to turn up their camera. And then for people using Zoom, meeting the mic, it's also very helpful. People find it very helpful. And then, yeah, other things is people engage on their phone calls and other things which they do during meetings. So most popular days to have meeting or Zoom calls is Tuesdays, Wednesdays, and Thursdays. If any of your colleague is somewhere else, for example, then there's a lot of benefit that comes with that, which I've already discussed. But what is more important is that for young people tend to have a lot of anxiety when it comes to virtual meetings because of the attention span and because of body image things. So we need to be cognizant of that. So why am I saying all these things? In essence, what I'm trying to say is that we need to have some level of digital literacy. I know it's not necessarily in our curriculum. We are deeply engaged in our clinical trainings when we were going through studies, and now we are working. Not necessarily do we pay attention to digital literacy in virtual meetings, which is becoming very, very important, even in the way we deliver clinical practice these days. So we need to have critical thinking. A lot of things that I've said require clinical thinking, critical thinking. In fact, a lot. And then we need to make sure of the internet safety, which I caution us. We need to be caution of digital plagiarism. Well, this has to do a lot with people copying and pasting in other professions, but it could apply to us when people use digital technology to write patient case notes. So we need to be able to use digital skills to search for evidence-based treatment, which is very important. And we need to really manage our online identity, which is very important as well, especially Gen Zs. So what all this encompasses, in essence, is that it's the ability to effectively find, evaluate, create, and communicate information using digital tools. That is it. Find what works best for you and your organization, but also what is approved by your organization. So the entirety of digital literacy is about you having the practical and functional skills to use technologies, have a critical thinking and evaluation skill, because it's not like face-to-face meeting where you could see body language. You need to make sure of e-safety because of data privacy. You need to make sure you are cognizant of cultural and social understanding of people. You had the story of prosthesis that is being painted black, and then it turns out to be rubbish for the patient. So it's the same thing. Some people have their own cultural and social understanding of digital tools. So you have to really be cognizant of that. Then you also have to have collaborative skill. Then you also have to have the skills to curate what is correct and what is not correct. And then you have to have this proficiency in communication with people and creativity as well, because you can't do a lot of things, especially in physical rehabilitation medicine. You can't do a lot of assessment virtually. You have to have that creativity to improvise way of assessing patient if you do attend to patient online. So the key component of digital literacy for virtual meetings is you need to have this technical proficiency, you need to have communication skills, you need to have information management skills, and you need to have security awareness. Well, I've mentioned some of the challenges, right? But just to recap again, um, the challenges is that lack of clear communication. People struggle sometimes to speak clearly in when using virtual technology. This could be from the technical hitches, but also from the individual differences we do have. Then attention spam. There is no time at moment in time that attention spam has dropped drastically across age groups than this era of TikTok, Instagram that we are, where people tend to appreciate that dopamine thing that goes in few seconds rather than really concentrate on meaningful information for a longer period of time. So we have to be very, very cautious and very careful of really what information do we engage people with when we have virtual meetings and for how long. Then a lack of formal relationship. Most of the times, the people you meet virtually, you never met them in person. And that's the case when you do clinical meetings or professional meetings with other people from other places. So that also is a challenge for having a virtual meeting. And then time zones, when you interact even across Nigeria, you kind of have differences of hours or minutes between regions. I mean, seasonal difference is not necessarily time per se, but it gets darker somewhere else earlier than some other places. So you need to also have understanding of the technical glitches. So network is always a problem for us. So we need to have a plan, backup plan for that. That's like extra time, getting people to settle first before you start and things like that. So the best practices for enhancing digital literacy is really kind of having pre-meeting preparation, have during the meeting encourage participation, and after the meeting make sure you ask questions if people really are on board on the same page with you. Choose the right platform and use the right tool to support yourself. This is just another example. In no way am I patronizing in this or marketing in this. I'm just giving it as an example for us to see. It might not necessarily be useful for you, but just to know that things like this exist where you could draw right the same time the way you could do physically. This is just to give us an idea of when to choose which tool. So the list of tools available today have grown exponentially. It's very hard to even remember their names, but the number of people you engage with, and again, remember I said earlier, approved tools are the tools that we can only use to engage with any conversation that has to do with patient problems because of patient privacy. You never know who is listening. You never know who is storing the data. You don't own the memory. You can speak on your phone, but where the conversation is being stored somewhere in the cloud, you don't have control of that. So you have to make sure that whatever you send on your phone or whatever you receive or whatever you record, if necessary, you know exactly where it is going, and it has to be approved by your institution for your legal protection. Then for one-on-one meetings, we can meet physically. For small group of say 4, we can have small room meeting in the hospital. And then for 50 people, for example, we can use things like what we have now, like Zoom. And for more than 100 or up to 250, we need to have something that can be able to support document sharing, document writing together, collaborative way of working together. So we have to also take account that some people might have disability, even though we're talking about patient, but we healthcare professionals sometimes tend to have our own problems. So we tend to have our own physical health problems, which makes us disabled. So we need to know that some people are deaf, dumb, or maybe physically disabled, which will require extra support to engage professionally in the meetings that we do. So we need to evaluate our skills constantly because digital technologies evolve faster and faster every day, and we need to look out on the evolution of this technology, which ones are more useful for us. For example, tools that are now coming up do have artificial intelligence embedded in them. I think even Zoom, it could clearly summarize the entire meeting for you after you finish because it listens to what you're saying. It can send you reminders in your calendar because it knows you have scheduled the next meeting in the next month. So they all have this artificial intelligence tool that is being embedded in them, so we can use it for good where it is necessary, but with extra caution because of the cybersecurity issues and the stakes we have of our patient data privacy. So I'm going to close with this. Whenever you have virtual meeting, uh, we need to make sure we arrive early. We need to make sure we keep our cell phones aside. We don't use cell phone. And then we make sure we don't interrupt because that creates the space more safer for everyone to contribute. And we need to have agenda uh, before the meeting. And we need to avoid eating because some people turn off their camera and then they keep on eating or doing other things and miss the entire key information and the essence of the meeting. So that's it. And I will close by saying this. The entire thing I've been talking about is words, when we articulate them properly and we say them in the right way, can change someone's mind and can change someone's belief. So we need to really choose our word properly when we have clinical meetings with other professionals, especially in our environment where we know that we have professional rivalry and we have the issue of two elephants fighting in the same room, which the patient suffers, like Gordon says. Thank you so much. I will take questions if you do have any. And are there any questions? If you have questions, you can raise up your hand, you can unmute yourself, and yeah. Are there any questions? Well, I cannot see questions. I'm not sure if MRTV could see any questions. Otherwise, yeah, we can. Well, thank you all. It's really a pleasure getting to spend the hour with you. If you do have any question, you can always reach out to me and you can discuss. Thank you.
Thank you so much. Thank you so much. to
Can't hear you, ma.
We can't hear you at all. Nothing.
Yeah, I think the network has
Okay, in the absence of no other further questions, Mrs. Ile has actually unmuted and ended the meeting. If there is no further question, that will be all for today. We can all take our respective leave and have a wonderful weekend. Thank you, everyone.
thank you.
Yes, ma'am.